Hello, everybody, and welcome to Hughes Clues Renal Dysfunctions. This is part one. One of the things that you'll need to remember is about the sympathetic nervous system and the RAS. These are both compensatory mechanisms that do occur in renal dysfunctions and will be addressed in the presentation. So if you need a reminder handout, be sure and email me. All right, let's talk about the kidney and some A&P reminder. What does the kidney do? And we know that the kidney's big job is to filter the blood. And when the blood is filtered, the kidney will get rid of water and waste. And wastes, in my mind, are identified as potassium, magnesium, phosphorus, blood urea, nitrogen, and creatinine. But in addition to water and waste removal, the kidney also does have some other functions, such as stimulation of red blood cell production because of erythropoietin secretion. The kidney controls acid-base imbalance, makes bicarbonate, regulates calcium absorption by activating vitamin D, another hormone that the kidney makes, ensures that proteins and red blood cells are not removed because those are very, very important in the body and we don't want to dump them down the toilet. And so these are the things are considered the metabolic function that the kidney does. So you have to keep all of these things in mind as we talk about the dysfunctions. And when we talk about renal dysfunctions, we divide it into chronic and acute. And we're going to talk about acute kidney dysfunction or acute kidney injury first, AKI. So what is it and who's at risk for it? So when we talk about acute kidney injury, this is kidney decline in function that happens suddenly. In other words, your patient's admitted to the hospital, they had good kidney function on arrival, but within that 24 to 48 hour time frame, they now are unable, or the kidney is now unable to do its job of filtering water and waste. Who's at risk? Well, 67% of ICU hospitalized patients are at risk for developing acute kidney injury, and of those 67%, 70% will have a mortality rate. So in other words, be at risk from dying. Yes, age and comorbidities are going to place a patient at a higher risk. So that just says to you, the nurse, that if your patient is young and at a traumatic injury, their risk of getting an AKI is still present if they're in the ICU, but it's less than that patient who has, say, heart failure and diabetes and hypertension that's in the ICU. So that's what the risk kind of concern is. All right, so let's compare the causes of prerenal AKI versus intrarenal AKI and postrenal AKI. These are objectives in the course. And really, if you're thinking, why do I have to know these classifications in the first place? Because the cause of the injury, really where it occurs in relation to the kidney itself, really does help the healthcare provider, the physician or nurse practitioner, identify a more specific treatment option. And the whole goal is to preserve that kidney function, to be aware of what can occur and to really nip it in the bud, so to speak, and treat and prevent it from occurring. So when we talk about pre-renal AKI, we're talking about problems or factors that are external to the kidney. But those factors will cause decreased renal blood flow or decreased perfusion to the nephrons, to the glomerulus, to the kidney tubules. And really, to my mind, that's pretty yappy. So the best thing for me that I think of with AKI is any problem that causes decreased cardiac output. That's where your patient is at risk for prerenal AKI. So that really gives you a big list of problems, because any kind of shock state, such as hypovolemic, cardiogenic, septic shock, or distributive shock, can really put your patient at risk for low cardiac output and therefore prerenal AKI. Now, there are times, kind of the outlier, where renal artery difficulties or problems such as tumors or strictures from atherosclerosis. This can also cause prerenal AKI, and they can occur and they're present, and I've seen them in my own bedside care, but they're not as common as your shock states or your other long-term health problems causing prerenal AKI. Another classification is intrarenal AKI, and this occurs because of conditions that cause direct damage to the nephron. Again, the nephron is identified or defined as either the proximal distal convoluting tubule or the glomerulus, or there could be direct damage to both portions of that nephron. But the bottom line is the damage to the nephron causes the nephron not to do its job. And there are lots more different things that can occur that will cause intrarenal. And one of them is if your patient has prolonged prerenal ischemia. In other words, let's think of your patient with heart failure. And with heart failure, the cardiac output is likely to go way, way down in the dumpster. And so if your patient has a low cardiac output, well, number one, the kidney's not able to do its job because it's not getting blood. Can't filter blood if there's no blood hitting the kidney. But you also have to remember that the kidney is a live organ and it has to receive oxygenated blood. So if there's less of a cardiac output, then that kidney is receiving less oxygenated blood. And so those nephrons can be directly damaged from the lack of oxygenated blood. Other things that will cause intrarenal AKI or nephrotoxic injuries, that's going to be your drug categories that cause direct damage, or things that we give patients for tests such as contrast dye, myoglobin release with rhabdomyolysis. Rhabdomyolysis and myoglobin release can occur with burns or can occur as an adverse response to the administration of a statin, such as atorvastatin. These are drugs that lower cholesterol. Rhabdomyolysis and myoglobin release can occur with crush injuries. These are traumatic injuries, or it can happen with sepsis. So again, you can see the very long list of different problems that will directly cause damage to the nephron and subsequent intrarenal AKI. Then we have postrenal AKI. 40 years as a bedside nurse, never seen it. But it can occur. And what it's defined as is any condition that causes a mechanical obstruction of urinary flow. In other words, the flow of urine down and out from the kidney, down the ureter, out of the bladder, out of the urethra. Any of those problems can cause an acute kidney injury. Now, when we talk about renal dysfunctions and specifically acute kidney injury, and there were 3 different classifications, we've got to be able, you, the student in complex needs, have to be able to distinguish identification of who's at risk and what's the scenario. So it's really a clinical kind of judgment and a clinical scenario. And so that's why I've got a clinical scenario and we're going to work through it and then figure out what kind of AKI is present. So you can see that this is that you potentially are caring for an elderly man, 78-year-old, whose second post-op day of a colon resection from a ruptured diverticulum. He's really a pretty healthy guy. He only has diverticulosis in his past medical history. The surgery was uneventful, though probably fairly lengthy. He's NPO. And on assessment, we see that the urine output for the last hour was 30 mils, but the previous hour was 25 mils. There's your vital signs, his weight, the medications that he's on, and note that he is getting IV fluids at 150 mils per hour. So let's look at these assessments characteristics and so find out how does this relate to a concern with acute kidney injury. And first of all, the easiest assessment for us to do was the urine output. And we could see that the urine output was 30 and 25. And so is that bad? How much urine should he produce? And so the amount of urine that patients should produce in our course and truly in the literature is that each patient should provide or produce anywhere from 0.5 mils to 1 mil per kilogram per hour. Or if the patient produces less than 400 mils per day, then this is a concern. So we identify that any patient who produces less than 0.5 mils per hour or less than 400 mils per day is likely in some kind of the oligurate phase of acute kidney injury. So at 80 kilograms, he should produce 40. Now, I do want to note this caveat because truly on tests, you're not given a lot of opportunities to think because you got to move through a test pretty quickly. And so if you're given an assessment of urine output and it's only one urine output, then you consider that there could be a problem, but you really want to know what's the time frame of low urine output because you really should consider it over 2 consecutive hours. And here's what I mean. Let's say your 80 kilogram patient produced 25 mils from 8 to 9 a.m. But from 9 to 10, they produced 110. So when you add the 2 hours combined and you average it, well, then they are well over that half mil per kg per hour. So you really want to not freak out with a 1 hour assessment, but when it's 2 hours or even 3 hours and that low urine output is now seems to be trending, then that's when you, the nurse, are going to go, all right, I need to be concerned about that. And if you see this oliguria or low urine output, what kind of classification of acute kidney injury could this patient potentially be developing and why? And what do I mean by that? Well, you've got to remember that this patient has a low urine output. And this patient could be at risk for a prerenal or intrarenal AKI. And here's why I say that. If they are at risk for prerenal AKI, it could be because of hypovolemia, the patient's NPO. The patient just had surgery. Perhaps they're somewhat dehydrated. So now we have to look at other assessments. We've looked at the urine output, but we have to look at other assessments. And so, of course, always a good assessment to look at is the blood pressure and the heart rate. The blood pressure is on the lowish side, but when we look at the heart rate, we see that the heart rate's 88 and the blood pressure is 110/55. If this patient was truly experiencing a volume depletion, then that heart rate would be way up higher than 88 for that blood pressure. So we can't just say, well, the blood pressure's low, he's dehydrated. No, we have to look at the heart rate too, because that's how sympathetic nervous system and RAS works. If the blood pressure goes down, or if the cardiac output goes down, then RAS kicks in Johnny on the spot and we get a rapid heart rate. We don't have that. So perhaps this patient's not dehydrated. Then we also look at the list that there was Ringer's lactate going at 150 an hour. Well, that's quite a bit of fluid. So it is likely that this patient is not dehydrated. So we probably can rule out prerenal AKI. And so that leaves intrarenal AKI as a potential problem. Now, what puts this patient at risk for prerenal AKI? Well, we know that the patient is receiving gentamicin, and that is a potentially nephrotoxic drug. So now we think, well, this patient is more likely to have intrarenal AKI, but we've got to look at more things before this determination is going to be made by us, the nurse, and also the physician. So now we're going to look at the metabolic panel, all of the electrolyte, laboratory, and the BUN and creatinine. We're going to look at the urinalysis. These are things that will also tell us about the kidney function ability. And then we also note that on the urinalysis it is reported that there are casts in the urine and that there is higher sodium in the urine than is what normal. So what do these clues or any of the laboratory values provide us? Clues do they provide us? So we look first at the BUN and creatinine because really if it's kidney, you better think BUN and creatinine. And we see that both are elevated. Now BUN and creatinine are wastes, and if they're elevated in the blood, then that means that combine the elevated BUN and creatinine with a low urine output, the kidney's not doing its job. It's not removing water and it's not removing waste. Now, I do want to kind of do a sidebar on BUN and creatinine, and I want you to remember or put in your head that a kidney problem will cause both an elevated BUN and creatinine. And so if you just look at the BUN on its own, the BUN elevation on its own can reflect other problems that aren't necessarily related to the kidney. So if you want to identify a kidney problem, you have to look at both BUN and creatinine. Both are elevated, plus the fact that there's low urine output. We're on the track for a renal dysfunction. Now we look at the serum sodium level and we see that it's decreased and that there's a lot more sodium in the urine. And so this is also a clue for intrarenal AKI. For the most part, the patient really does, or the kidney holds on to sodium. It keeps it. It's very important in the functioning of our cells. And so most of the sodium is kept. And when there is an excess of sodium dumped in the urine, then there is a consideration that, you know what, the kidney's not doing its job. It's not keeping the things that it normally should keep. And so this also is another clue that there is a nephron that is not working the way it should be. The kidney is also not concentrating the urine because the specific gravity is very low for the fact that the urine output is very low. And so this could be a concerning part. So what I want you to get from this slide is that, yes, we look at 2 hours at least, if not 3 hours of urine output. That will tell us whether the urine output is declining or not. And then we have to look at the BUN creatinine, the urinalysis, which will give us the specific gravity and the substances that are in the urine. Now, many of you probably don't remember specific gravity, so we're going to do a very quick side trip, and that is just to very briefly tell you what is specific gravity. Well, we know that the kidney's job is to get rid of waste and water, and therefore in the urine you should see waste and water. But it's not just that the kidney gets rid of waste and water willy-nilly. The kidney gets rid of waste and water in a very specific ratio. In other words, specific gravity is really telling us about the urine concentration. In other words, the ratio of how much water is being removed in relation to how much of the waste is being removed. So what you need to know for this course is that specific gravity is a urine test that indicates whether the kidney is properly doing its job of removing waste and water. If you want more information on the topic, email me, but don't bog down. You got too much to know. All right. So now we're going to go back to all the clues. We've got clue number 1. The patient is not making a lot of urine, even though he's receiving a lot of fluids per hour. So the kidney's not removing enough water, enough that it should. And the specific gravity is very low, which means that the kidney is not doing the other part of its job, which is to get rid of waste. And so that's what that specific gravity is telling us. Low urine output and a very low specific gravity tell us, yikes, this patient's not removing water or waste. Now, we also got in the urinalysis that there were casts. What are casts? Casts are dead tubular cells. In other words, the cells that line the kidney tubule, the distal and proximal convoluting tubular, there's live cells there that do the job of helping with removing of water and waste. And if there are casts in the urine, then that means they're dead tubular cells. And that's not a good thing. That means that that tubule has had some dead cells more than what it should, or I don't know if there should be any casts in there. And therefore, you can say that this patient has a acute tubular necrosis. Necrosis means dead. Tubular means tubular cells. Casts indicate acute tubular necrosis. Now, the problem with these casts is that they can clump and then cause an obstruction. But you put all of those things together, the fact that casts are there and that likely those casts are clumping and causing obstruction, and you put those things together, and that equals intrarenal AKI, and that's how your physician can diagnose this. Now, I will do another sidebar that's not really addressed in the course, but there is actually a lab test that will test for those tubular cells. It's very expensive because it's a newish test, and so that is also used, but that's a clinical note and not a testing note. Now, We move on with our scenario, and we note that on post-op day 3, his weight is 82 kilograms. So he started out at 80 kilograms on admission, and now he's 82. So what does this indicate? Well, it's not deliciousness of food from hospital because he was NPO. It means that he's holding on to water. Because when your patient jumps in a very fast amount of time, 3 days, he's jumped 2 kilograms, that means that he's likely holding on to 2 liters of water. Each liter of water, or 1,000 mils of water, equals 1 kilogram. So again, this confirms what you've already suspected. This kidney is not getting rid of water. And so this is a problem, and all of this has to be reported to the physician or nurse practitioner, and then that is where the diagnosis will come in. So we've also talked about the fact that this patient is gaining weight, and the nurse also is now assessing that he appears to be confused. He doesn't know the date or the place. And he's complaining of nausea, and he's not interested in eating, even though it's 3 days post-op. So what do all these signs and symptoms mean? And you just have to know terms. The cause of his confusion could be uremia. When we talk about uremia, uremia means that the patient has azotemia, which means elevated waste, the BU and creatinine, and the patient has signs and symptoms. So when you hear a physician say, oh, this patient is uremic or has uremia, that means not only are the wastes and water accumulating, but the patient's body, his brain especially, is showing signs and symptoms that the elevated wastes are adversely affecting his brain cells. And so that means it's bad, because it's not just enough that wastes are elevating, it's that they are negatively impacting this patient. He has uremic encephalopathy. And so that's why this is important, that we report all of these things and consider all of these things as we take care of our patient. All right, so it was identified previously that the patient is in the oliguric phase. What does that mean? What's the oliguric phase? And note that there are 4 phases of acute kidney injury. And we see them here. They're listed here: initiating phase, oliguric, diuretic, and recovery. And all of these are defined from the course lecture notes. I don't think it's important that you memorize these. I think you be aware that these can be present. You might write when the oliguric and diuretic phase are identified. I think these, of all the 4 phases, are the most important for you to note. Again, don't memorize them. Write them down on your exam sheet so that you get all those points. Do notice the criteria. I've got care priority there that are seen in the oliguric phase, the care priority that is noticed in the diuretic phase. And so again, it's a nursing course. Nursing interventions are going to be what you're going to be tested on. So as we go through the rest of these renal dysfunctions, which will seem like forever long, this is where your focus needs to be. All right. Let's talk about the rationale for the laboratory values if our patient was diagnosed with pre-renal AKI. So we see all of the things that the patient has, and I've got the urinalysis that, oh, I'm sorry. Let me back up a little bit. We just finished the intrarenal identification. And so then I showed you the different phases of the acute kidney injury. So now let's talk about what you can expect to see if your patient was diagnosed with pre-renal AKI. So in other words, we just finished what you can expect to see if your patient was diagnosed with intrarenal AKI. But what would you expect to see if your patient was diagnosed with pre-renal AKI? They are different. And there's some subtleties, and the reason for the subtleties is where I'm going to focus. All right, so here's your patient assessment that we see that there's less than 400 mils per day. Ding, 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 we know that this is bad. And then we look at the analysis, and we see that this patient has a low urine output. That's the first clue that they could be developing an acute kidney injury. And we see that the BUN and creatinine are elevated. And so that really says to us that's the criteria that says that the patient has an acute kidney injury. What would say to the physician, well, this is prerenal AKI? Well, we already identified in previous slide that prerenal AKI is all about the cardiac output, that hypoperfusion or low blood delivery to the kidney is what's going to cause a prerenal AKI. It's problems before the kidney. So let's talk about what happens in normal land when your patient or your kidneys respond. How do they respond when the cardiac output goes down? And we know that the cardiac output, as soon as it goes down, that the kidneys, within a very short time, they will initiate the RAS, the renin-angiotensin aldosterone system. And when the kidneys initiate RAS, the kidney will cause that angiotensin 2 will cause aldosterone to be present, and the aldosterone will cause the kidney to hold on to sodium. So if you look, and water. And so when you look at this urinalysis, we already know that the patient's oliguric, meaning they're holding on to water. So water is not being renewed. We know that wastes are accumulating because the BUN and creatinine is elevated. But when we look at the urinalysis, we see that the urinalysis is really high. And we also see that there aren't any casts in the urine and that there is low levels of sodium. I said earlier that most sodium is kept by the kidneys, but there is a small amount of sodium that can be dumped in the urine, especially, let's say the patient eats a bag of pretzels. And so there is some sodium that can be dumped. So there's always the normal range of sodium that the patient should dump in their urine. And in this instance, in this patient scenario, the patient has a low level of sodium in the urine. So why is that? What does that tell us as we determine whether this is a prerenal, intrarenal, or postrenal? Well, we know that when it's prerenal, that as soon as the cardiac output goes down, we know no matter what the cause, it doesn't matter what it is, the cardiac output's down, the kidneys go, yo, I'm not getting any blood here, then the kidneys will do RAS for whatever the reason. And therefore, they will have, with aldosterone, hold on to sodium and hold on to water. And so when the kidneys hold on to water, the urine output goes down. And when the kidneys hold on to sodium, the amount of sodium that should normally be dumped into the urine also goes down. And so therefore, this patient has low urine output, low sodium in the urine, no CAS, which means there's no way this is intrarenal AKI, and the specific gravity is on the high end of normal, and therefore the concentration of the urine, in other words, the patient is appropriately, the kidneys are appropriately removing water to waste. So again, the specific gravity, the concentration of the urine is okay because the kidney is still working. Now, how the heck does that compute in your head for prerenal AKI? Because we know that there's a renal dysfunction. But then you're telling me that the kidneys are still working? So this is why prerenal AKI is so annoying and so confusing, because what has happened is there is a decrease in cardiac output, but the kidney nephrons are still doing okay. In other words, they're not dead. They're still working, and they essentially are doing what they have been born to do, and that is as soon as the cardiac output goes down, then they initiate RAS. You must remember that the kidney nephron doesn't work as a mass group. Each kidney nephron works as an individual, and therefore they don't talk to each other and say, yo, how's your cardiac output? Mine's really bad. Is yours okay? No, each nephron, as soon as its cardiac output or blood flow is reduced, it'll initiate the RAS. And so that kidney nephron, if it is able to initiate RAS, it's still alive. It's still able to hold on to water and hold on to sodium. Now, for your patient's point of view, it's not helpful, and it means that the kidney is not working the way you want it. The healthcare provider wants it to work because this patient has heart failure. We don't want them to hold on to sodium and water. So it's a problem, and it's a problem for the patient. So the problem has to be fixed. We have to get that cardiac output up so that the kidney will then stop doing the RAS and start getting rid of all of that excessive volume that your poor heart failure patient is holding on to. So, what I want you to get from this and what's in the course is that with pre-renal AKI, the kidney nephron is still working, but it's not working the way we want it to work, the way we want that patient to have their kidney function. We want that water and we want that waste to be removed. And when that kidney is going berserk by doing a bunch of RAS, that's not helpful in several scenarios. And so, if the problem is not fixed, again, if the cardiac output can't be fixed, then we know that the nephron will then die and the kidney will move into intrarenal failure. So, that is really the key difference between prerenal and intrarenal. With pre-renal, the kidney's not working because the cardiac output is low and waste and water are being held onto. But the kidney nephron is still alive. It's struggling, it's ill, but it's still alive. And so, therefore, we don't really think, or we have to focus in pre-renal on not so much the kidney itself and fixing the kidney. We have to focus on fixing the problem. And so that's why the problem has to be fixed so that the cardiac output has to go up so then that the kidney will then get healthy again. I hope this has been helpful. If you have any questions, be sure and email me.